Okay, and now we'll start what we're here for this evening is the Sir Victor Horsley annual lecture. And it's always an interesting process that we go through to choose the lecturer. And I'm going to introduce our lecturer in a minute because he is absolutely an amazing person. But first, I just want to remind you about Victor Horsley, and we tend to drone on and on about Victor Horsley here as our first neurosurgeon, and we have all of these stories and everything about him that we do like to tell. And so I'm not going to do any of that. All I'm going to do is to put him in context of our theme of tonight's lecture, which is global neurosurgery. And that is one of the many things that the well-rounded Victor Horsley thought about. And Horsley certainly was a key person in the Royal Army Medical Corps in World War I, where he kept volunteering over and over to go back either to the front lines or to various hospitals. He was a colonel in the British Army Hospital in Egypt at one point, and after that he was done his tour, and he went back to Mesopotamia, which is where he met his untimely death at the age of 59 probably from heat stroke, it sounds like. But he was out there in developing countries long before we had the term global neurosurgery. Now, in fact, yes, he was there as part of the army, but these were absolutely things that he was passionate about. So it's very apt, I think, that today our lecture is in global neurosurgery. Very often it's been in functional neurosurgery because we think of Horsley as a functional neurosurgeon, which he was, but he was much more than that. So I actually have some notes because there's just so much about Kee Park that I would like to introduce you to, but I have to really keep it down because you don't want to listen to me, you want to listen to him. And so we will get him up here, but give me 2 minutes. Sometimes it's always a real pleasure to introduce our Horsley lecturers because they have been absolutely outstanding people. And once in a while you read a CV, like I did of Kee Park's, and you ask yourself, what have I done with my whole life? I've wasted my life. and that's how I felt reading his CV. I mean, it really got me to ask questions. He has done absolutely remarkable work. Kee and I are probably of about the same vintage. We both graduated from medical school at the same time. So he's 1989. He did his MD at Rutgers. And I'll just note that 30 years later, he did a master's in public health at Harvard. So the question is, well, what happened in between 1989 and 2019? And that's where I could go on forever because quite a lot. He started off with an internship and a neurosurgery residency that he completed in 1995 at Temple. And then he moved to, and I have to read this name of this place, Cape Girardeau, Missouri, which none of you probably have heard of. Cape Girardeau currently has a population of about 40,000 people. And so I would imagine that that was a big change for Kee. And he was there with his wife, who's here for the lecture. He was there for about a dozen years practicing neurosurgery. And I think, from what I can tell, was very happy there and everything, but always wondered if there was more to life than practicing neurosurgery in Cape Girardeau, Missouri. So in 2008, he and his family decided that they would take a sabbatical, even though it wasn't really a sabbatical because he didn't have an academic appointment, but they traveled around the world, and he ended up after talking to many people about the issues of global neurosurgery, ended up in Addis Ababa for he spent about 5 years there on and off, I think, helping with neurosurgery. He tells me that he made a few mistakes initially, as we would do, doing something completely different. You can't just take Cape Girardeau neurosurgery and transplant it into Addis Ababa, but he undoubtedly learned a lot. From 2009 to 2019, he made a couple of dozen trips at least to Pyongyang, North Korea, which I think is something quite impressive. In that period of time, he also spent time in Cambodia, in Phnom Penh, And I think there was some mention of Nepal at some point, and maybe even of Ecuador at some point. I'm not sure about the Ecuador connection. Anyway, he's been all over. And I have to emphasize that since 2009, all of his clinical work, Kee, I don't think I said Kee is at Harvard right now. He comes to us from Harvard. You may have heard of that East Coast university that sometimes rivals UCL. But all of his clinical work since 2009 has been abroad. It has not been in America. His clinical work has been all over the world. In 2008, for 8 years, he was a volunteer for FEANS. That's the Federation of International Education in Neurosurgery, really into educating neurosurgeons and neurosurgical trainees around the world. From 2017 to 19, he was involved with the Emergency and Essential Care Program at WHO, an institute that America used to support. And from 2019 to 2023, in 2019, he became the inaugural chair of Global Neurosurgery Committee of the World Federation of Neurological Societies, and was there for 4 years. In 2016, he established a global initiative, which is the Global Neurosurgery Initiative, a key research team at Harvard's program in global surgery and social change. And in that institute, he became the director for Korea Health Policy Project in 2019, and the director of policy and advocacy in 2020. In 2020, he also became the editor-in-chief of the Journal of Global Neurosurgery. He's got a huge list of mentees on his CV and has published key papers in the field with many of them. And his success really is based on his philosophy to use local data to influence guidelines and policy. And I think that that's really key. He's not just talking about things at the hospital level or at the neurosurgeon patient level, but really to influence countries' guidelines and policies. I also want to note that he seems to be equally comfortable talking to politicians and clinicians. He was involved in trilateral dialogues between the USA, Russia, and China on the Korean Peninsula, and has briefed US senators and foreign missions about North Korea. He's written many articles for the public, including op-eds in the New York Times. The one on hunger in North Korea was very interesting, and if you want to read it, you can find it online. He's appeared on many radio programs. He's a frequent speaker around the world about global neurosurgery, so I really think that we're lucky to have him here, and especially at a time, I'm sure in his life, that's fraught with all sorts of issues emerging from the current US presidency. So it's really an honor and a pleasure to have him here and to hear what he says. His title is Global Neurosurgery, Why It Matters. Thank you.
You're so kind. Thanks, Rob. Wow. First of all, let me just say, Harriet, thank you for sharing the fact that you didn't get some of these talks. Like, you went over my head as well. I was thinking, oh my gosh. Outstanding talks today, absolutely. It was a privilege to be a part of that. And you mentioned that Sir Victor Horsley was probably one of the original gangster global neurosurgeons. And I actually agree with you. In addition to working in these developing countries, he was also an advocate for a public health insurance system in the UK. And this is really what the essence of global neurosurgery is. It's not always about how to do surgery better, but how to make neurosurgical available to those who all need it. So yeah, sir, I just found that connection to be uncanny. All right, let's see here. Gosh, is this the keyboard here? Okay, here we go. Let me start off with the definition of global neurosurgery. If you ask 10 people, you get 10 different definitions. And when I was the inaugural chair of the Global Neurosurgery Committee of WFNS, the first thing we did was, let's get a definition that we're all going to use together. And I really like this. It's the clinical and the public health practice of neurosurgery with the primary purpose of ensuring timely, safe, and affordable, TSA for short, timely, safe, and affordable neurosurgical care to all who need it. And that, to me, is so important, to all who need it. Because really what we find out in the world is that not everybody who needs neurosurgical care can access it today, right? I love this picture. It's not original, it's not mine, but it really demonstrates the world that we live in and the things that we're doing to try to correct that. So let's be honest, the world is not equal, right? Even within the UK, there may be areas where some people have better health care than others, and for sure in the disparities between high-income countries and low-income countries is remarkable. So if this tree is the tree that gives out, the fruit, and the tree tilts to one side. Okay, this is the unfairness of the world that we live in. And then let's just say the apple is neurosurgical operations. So you have one group of people that really can have neurosurgical treatment whenever, wherever. US, UK probably, but there are places around the world that neurosurgical care is not available or accessible. And that gap is actually 5 million neurosurgical operations currently are not being done when needed. And most of that is in developing countries. So how do we address that? How do we fix that? So one idea is, well, let's give everybody, make sure neurosurgical care is available to all, right? It sounds fair to me. Let's make sure that every place in the world has a neurosurgical facility, and it's right there. If you want to go get it. The problem is, it costs money to deliver neurosurgical care. And so for most people, even if there's a hospital right in front of you, if you needed neurosurgical care, they can't afford it. So just having neurosurgical services available, although it sounds equitable, it is not, it's still not fair. It's not accessible. Availability does not equate accessibility. Even if you were to able to afford it, some of the apples on that side, they're not as good quality, all right? The operations that we receive in London and Boston, high quality. But imagine if you're a neurosurgeon working in Jamaica, Kingston, Jamaica. I think, someone was talking about that today. And the quality can vary dramatically. So is it safe? Is it affordable? All those things are important. So I think the better thing to do is to make sure that we provide different levels of support so that anyone who needs neurosurgical care can get it. So one thing is you have to make sure the tree has fruit, right, the operations available, but then you need to provide additional support so that people who need neurosurgical cases, operations can access that. And that's the basis for health equity. This is the kind of work that we're doing in global neurosurgery. What I've discovered over the last 10, 15 years of working in this space is that while it's important to try to fix address the deficits in neurosurgical care, I think it's also our responsibility, at least I feel that it's part of my responsibility, to straighten out that tree. The tree is not straight. There's a reason for that. There's structural and systemic reasons why the tree leans to one side. And that's the social justice part that I think it's so important for all of us to embark on. Now, the problem is, this is a great quote. This is a gentleman who is a priest. He's part of the liberation theology movement. He said that when I give food to the poor, they call me a saint. But when I try to ask, why poor have no food, they call me a communist, right? When you start questioning the structures in place, when you start questioning why, then the people who are benefiting from the fact that the tree is leaning to one side, you are now our target. And we are seeing this now in the US playing out, right? And it's actually the people like this Father Camara, he's being, labeled as communist, or we're under attack. So I think you saw the news, right? USAID, the largest bilateral, global relief agency, if you will, is being taken down, right? It's being put in through the wood chipper, as Elon Musk is saying. And that picture to me is just so jarring. Having someone go in there, remove those letters one by one from the sign of the building, USAID. I used to, I went in there multiple times to meet with officials. One of my colleagues, Dr. Atul Gawande, who's an endocrine surgeon, by the way, he was the assistant administrator for global health for USAID under a Biden administration. And I am so happy that he's actually taking a stand on what's happening today. I believe that what is happening is an attack on global health, and there are severe consequences to what's happening in this world now, right? You know, there's relief agencies closing left and right. MSF is closing in Sudan. I mean, there's list after list of things that are happening because so many of these relief agencies and humanitarian organizations were being funded by USAID, and then all of a sudden money's dried up. And he's taking a stand, and I would, you know, so I'm a U.S. citizen, I voted, right? And so we have an extra responsibility in the U.S. to speak up against some of the impact, the consequences of these actions and the policies of the current administration. But we really need you all to keep U.S. accountable as much as possible as well. The international community, we need you. So a lot of times when grants are submitted, right, there's actually a scrubbing app that looks for keywords, and then it triggers a more detailed review of a grant. Right now, my understanding is that these are the words that are being used to trigger a review. When I say review, probably a rejection right off the bat, okay? Look at these words: women, underserved, socioeconomic, privilege, marginalized, equity. I mean, who doesn't use these words, right? So this is really scary, everybody. This is this is the world of global health that we're entering today, and it's a frightening time. But I have to believe that we have a moral imperative, and I think humanity dictates that every one of us, and I think people in this room will agree, and that's the reason why you came to this lecture, is that we have a responsibility to take care of everyone, right? This is our, it's not just all about us, it's about everyone who needs, who are down and out and underserved. And I believe that Martin Luther King used to say the moral arc of justice is long, but it always bends towards, the right side. And I believe that this will eventually get better, but it's going to be a battle. Why is defunding USAID important? If you look at this IMHE picture, the yellow is United States. This is mostly USAID. And if you look at this is the global, the overseas development in health, the total amount that's being that's available. It's broken down by countries and also philanthropy. U.S. government is really the one single largest funder or source of money for development assistance in health, around 8 to 9 billion. That's going away. We're not sure in what shape or form it's going to resurface. If you look at number 2, it's actually private philanthropy and Gates. If you combine them together, it's about $6 to $8 billion. But that whole yellow section used to be U.S. government, and we're not sure what's going to happen. You can argue that $8 to $9 billion is really peanuts, and it's true. We need to do more for to share. High-income countries should do more to share their wealth with poor countries, but that's another discussion. But I believe that we don't do enough. Okay, I like this op-ed by Nick Kristof. He's really an amazing writer, and he talks about the world's richest man, and you know who that is, Elon Musk. He's boasting about destroying USAID. He's boasting, right? And USAID, and he says he shoved it into the wood chipper. And just so you know, Elon Musk's personal net worth since the election has grown more than the entire USAID budget. So where are we going with this world? I don't know. We need help. All right, so change a little bit of gear, and we're going to talk a little bit about my journey into global health. As Rob said, that I was in private practice for about a dozen years in Missouri. My wife is here, and we had a really posh life. About 7 or 8 years into it, it became clear that we're really, really lucky, and we hit the jackpot. A private practice neurosurgeon in the U.S. is really a privileged place to be. And we came across a verse from Luke, and it said, "To those much has been given, much is expected." And for us, we felt like there was a reason why we were so blessed. And then we said, maybe there's a way for us to do something more meaningful than just work and gather more stuff. And so we planned, and at 12 years into my private practice, we were able to shut the doors, and then I was able to enter into overseas volunteer work. Initially in Addis Ababa, which had 3 neurosurgeons for a population of 90 million people, and all in Addis Ababa. So imagine, if you're living in Gundar, and you had just a simple epidural, and you don't have anyone to take the blood clot out. So what does that mean for the population? To the Ethiopians' credit, they started a residency program, in 2006 or 7, and they were looking for volunteers to come and teach, and I was able to be a part of that. And to this day, some of my best friends are Ethiopian neurosurgeons, because I was part of that initial group of people that were teaching, and now our residents are now teachers and then professors, and it's been a success story. I did work a little bit in Nepal. In 2013, I did move my whole family to Cambodia, Phnom Penh. I worked at a government hospital, a major trauma hospital, and my wife worked at an international school, taught English, and then my 3 daughters went to school there. And visiting Ethiopia 2 weeks at a time, even though, like 4 or 5 times a year, was really important, and I learned a lot. I learned so much more by living in Cambodia and going to work every day and working at this government hospital. I saw that a person that was being admitted to the hospital with head injury from a motorcycle accident, GCS of 10, let's get a CAT scan, come back on afternoon rounds, CAT scan's not done. It's like, why not? Well, they can't afford it, right? So, and there's that delay. And it was just heartbreaking to see that the way the system was in place. It wasn't the people in Cambodia know how to do the epidural operation, right? Subdural operation. It's not that hard, but it was the health system that wasn't fair. One of the things that we did when I got to Cambodia that I didn't do in Ethiopia was collect data. You also, you the ABCDs of research. Always be collecting data, and I learned that there. And we started following, mechanism of injury, type of injury, and we saw that, head injuries is probably the majority of things that we saw, and the mechanism was from road traffic accidents, mostly from motorcycle accidents, actually. And this is why. This is the primary mode of transportation, and people aren't wearing helmets, by and large. So we actually tracked and counted number of people that that weren't wearing helmets. It was 90%. These are people that are being admitted to the Preah Kossamak Hospital with head injury, with motorcycles, and 9 out of 10 were not wearing helmets, right? And interestingly enough, the type of pathology that we're seeing is low velocity, right? Head injuries, epidurals. I don't know about you, here, and I found out that you don't have a emergency room at Queen Square. But if you talk to your colleagues in London, other places with the trauma services, epidurals have gone down significantly. Most of the time, what you're seeing is high velocity, like acute subdurals. In Cape Girardeau, in private practice, probably 1 in 20 were epidurals, pretty rare. You go to Cambodia, it's half the case. And as well as I do, epidural operations are fairly straightforward. So we said, we need to do something about this. So we showed, and then Rob talked about how we were doing research on local data. This is one of the few cases where we were able to show with data that we collected in an LMIC, and that showed that if you didn't wear a helmet, the chance of you having worse admission GCS scores, the risk of going to the OR, and the risk of lower outcome scores, we showed all that, significant. And so once we published it, we went on to the next step. We started going to government officials, Interior Ministry, and saying, people are dying here and people are needing unnecessary surgery because they're not wearing their helmets. And you guys should start thinking about enforcing or strengthening your helmet laws. And sure enough, in January 2016, they passed helmet laws and they started ticketing people. And that's when I got this idea that, I can help the people of Cambodia not, as a surgeon for sure, but I can also help them by trying to improve the public health measures that can reduce the risk of injury. And that sort of tweaked my interest in global public health. And so at that same time, I got an email from a friend of mine saying, hey, did you read this Lancet Commission on Global Surgery report? If you haven't, I would recommend you read it. It was published in 2015. It's called Global Surgery 2030. And they approached the issue of unmet surgical needs in a very systematic way. They showed that it was responsible for almost 17 million deaths a year, the lack of access to surgery. And that's 3 times more than HIV/AIDS, TB, and malaria deaths combined, right? Well, no one was doing anything about it, whereas billions are going into HIV/AIDS and TB. Surgical conditions make up to a third of global burden of disease. 81 million people, when they have to have surgery, they have catastrophic expenses. And then poorest third receive only 6% of all surgeries. And then the number is 5 billion, more than half the world's population, do not have access to surgical care when it's needed. And then when I saw this, it really helped me to understand that the unmet neurosurgical needs that I'm trying desperately to help wasn't going to be fixed by teaching more and more neurosurgeons. There needs to be more of a public health, global health approach to the problem. So I came back to U.S., and I was in my 50s, and I applied for a fellowship with John Mira in the global program in global surgery and social change. John said, sure, come on in, and then you can start your global neurosurgery work with us. He also suggested I get a master's in public health, which I did. I loved it. It was exactly what I needed. But some of my favorite classes in MPH had to do with the politics of global health. And really, I'm a firm believer, if you see what's going on in U.S. government today, there you go. What we need is people who are interested in improving the health of populations to become as good or better than the politicians are. That's a challenge to you all, especially the young people. Learn how to be a good politician if you want to make a difference in health. Anyway, so I finished my fellowship, and then Paul Farmer and John Mira asked me to stay on as faculty at the program in global surgery and social change. And I joined, and then I started working on global surgery, right? That's the surgical needs, not necessarily just global neurosurgery. So it was a concurrent type of thing. I'm working on global neurosurgery, but also global surgery. We've been tracking global neurosurgery workforce. Some of you know our papers. The last one was with Sachin Gupta, we just published. Initially, our counts were 49,000 neurosurgeons in the world. That was our first study. And then our most recent study in 2024, our estimate is that we have about 70,000 neurosurgeons in the world, okay? That's our best estimate that we have today. And so you can say, well, the increase is great, right? It's like almost 40% increase over the last 6 or 7 years. The good news is there has been an increase. The bad news is that most of that increase has been happening in high-income countries. And in lower and middle-income countries, that increase is very slow and little. But I've been doing global public health and global surgery work since 2016 until now. I still work on global surgery type of work, some advocacy pieces about pandemic and surgical preparedness, the universal health coverage and where surgery belongs. We've been doing some regional work in Asia Pacific. So that's my main job, by the way. I do global surgery, even though I'm a neurosurgeon. But at the same time, I never forgot the fact that I'm a neurosurgeon, and one of my key activities is neurosurgery. But in terms of global surgery, what my work looks like is a lot of it is because I'm the director of policy and advocacy. We try to drive a political will in the various WHO regions. The picture on the left is in Manila at the WHO regional office. We just adopted the safe and affordable surgery agenda item. The middle picture is me with the Ecuador health minister. We just finished developing a national surgical plan along with the health ministry. The interesting thing is, so based on my global surgery work, I got a call from the US government through the National Institutes of Health, and they said, hey, can we talk to you about sending you to WHO? And we'll pay your salary, at least portion of it, so you can be released from your responsibilities at Harvard and work in Geneva with WHO. I said, great, I'd be happy to do that. So in January, like 2 weeks before the change in administration, the agreement got signed, and it was undergoing final ethics review. And then Trump came in and announced on the first day we're pulling out of WHO, and recalled all the U.S. secundees in the organization. So I'm actually a direct, I've experienced personally what the change in policy looks like. Okay, so in 2015, there was the Lancet Commission on Global Surgery, and the thing that's important is that the research, when it's done correctly and it's relevant and high quality, can change the entire landscape of global health. In this case, there was actually a resolution at the World Health Assembly in Geneva in 2015 calling for strengthening of emergency essential surgical care as a component of universal health coverage. This resolution is a direct result of the Lancet Commission on Global Surgery, as well as grassroots effort by people in global surgery. And what that called for was countries to develop national surgical plans. So this is a workshop that we did with WHO in Dubai, and we had a number of health ministries, and we had a number of workshops helping health ministries to go through the steps in developing a national surgical plan. And a number of countries have done that, including Nigeria, Rwanda, Tanzania, and here's the, so the Zambia was one of the first countries to develop a national surgical plan. And then in 2016, in that plan, they said we need to start a subspecialty training program, and neurosurgery was one of them. They took 4 people, and then 4 years later, they graduated. One of the first graduates, his name is Arnold Bebe. By this time, global neurosurgery had become sort of a buzz. There was a buzz around it, and the Congress of Neurological Surgeons, one of the major U.S. neurosurgical associations, started a global neurosurgery fellowship program for people from LMIC, and he applied. And so he applied, he was selected, and through that fellowship, he spent 3 months with us at the program in global surgery and 3 months with MGH. And for me, it was kind of heartwarming because he would not have existed if there wasn't initially the effort to try to get countries to develop national surgical plans and initiate that subspecialty training. So, and then Arnold, I think he's in the UK now doing a fellowship in neurotrauma, by the way. He's brilliant, he's awesome. His name is Arnold Bebe. So as I mentioned, this was in Manila in 2020. This is all of us after a vote on adopting safe and affordable surgery as an agenda item. And I just want to point out a few people here. There's a gentleman to the left wearing kind of a skirt type of thing. There's Minister Wanka. He's a surgeon. So a surgeon becomes the Minister of Health in Fiji. And he says, I want to support this resolution, this kind of work, because this is important to me, because that's where he's trained to do. And then there was another person from Tonga. He's an anesthesiologist. So you can see how sort of stars lined up in certain regions to bring everybody together. The gentleman next to me, the tall guy with the mustache in the center, is Hisham Abdullah. He's like a number 2 at the Malaysian Health Ministry. He's now retired, but he's also an endocrine surgeon. So we had sort of this little surgical cabal going, and that really made a huge difference. And there are others who I'll show you who's helped along the way, who are surgeons or anesthesiologists who turned politicians. So this is a group of health ministers from Latin America coming together, and the gentleman in the sort of with the bald gentleman, tall guy in the middle, his name is Alfredo Borrero. Does anyone know who he is? Just curious. He's from Ecuador. So he's a neurosurgeon who was the vice president. And they just, this was there's a new government, but he's the previous vice president. And at that time, when he was vice president, he asked the Program in Global Surgery, our team, to help with his Ministry of Health to develop a national surgical plan. And then we also asked him if he would drive surgery as a health issue for the Latin Americas. He said, of course I will. So this is, there's now also a resolution within the PAHO, Pan American Health Organization, which is the WHO regional office for the Americas, with a surgery as a priority item. So this is how we get policies in place that allows, that really primes the ministries of health to put surgery on their agenda, so that if there are mission groups that are going into country X, it's easier, right? They either have a plan or they are looking at surgical care as something that they could support at the ministry level. Okay, so now we're gonna switch to global neurosurgery. That was just a backup story on global surgery and what's going on. There's a lot more happening. I'm happy to talk to you in person. This is a book that's available at the WHO bookstore. You can go there today, okay? And this is the only book that I'm aware of that is really about surgery. It's called The Surgical Care at the District Hospital. If you look at the table of contents, they do have one neurosurgical procedure. It's called cranial burr holes. And it's listed under orthopedic procedures. Now, I don't know if there's any orthopedic surgeons here, but as a neurosurgeon, that makes me very cringy, okay? I'm not comfortable having a neurosurgical procedure listed as a orthopedic procedure. But that's because neurosurgeons were not at the table when this book was written. That has changed. That has changed dramatically. And the new version is gonna have proper table of contents. So what happened? Remember, May 2015 was when the Lancet Commission on Global Surgery published their report, Global Surgery 2030. I read it, and then Walter Johnson was just hired. There's a gentleman next to me in the middle. He was hired by the WHO to implement the Resolution 6815, which is the Emergency Essential Surgical Care Resolution. Walter Johnson is a neurosurgeon. So he's hired by WHO to implement it. So we meet actually in Rome. I meet with Walt, and then the gentleman on the right is Bob Dempsey. He's the president or chairman of the FINS, the Foundation for International Education in Neurological Surgeons. It's a U.S. NGO that sends neurosurgeons to help train. The three of us are at this meeting at WFNS in Rome. It's like, did you read the report? Did you read that article? It's like, yeah, we got to do something, okay? So so Walt actually was in Geneva. He invited a number of neurosurgeons to a consultation meeting about how to create a roadmap to implement Resolution 6815, the global surgery resolution. But he invited about 4 or 5 neurosurgeons to that. I was there, and we started strategizing on how do we get global neurosurgery introduced and call for action within our profession. Right? That was our number one question. So there is this thing called Cotter's 8 steps. Okay, you can just Google it. You can take a picture of it if you want, but it's on the website. And this is something that's taught at the School of Public Health on sort of one way to help make changes in an institution or somewhere, a company or whatever organization that you belong to. And the beauty of this is that it works. It's simple. If you follow it, so it worked for global neurosurgery, and I'll sort of lay out how that worked. But first, you have to create a sense of urgency. Then you need to build a guiding coalition. You need to form a strategic vision, right, and then communicate that over and over again. You need a volunteer army, a grassroots army. You have to eliminate your opposition, okay? And then you generate quick wins, right? And then you sustain acceleration, and then we need to institutionalize change. This works. And this is exactly the playbook that we followed to institutionalize global neurosurgery. And I'm going to show you how that worked. So remember, we met in Geneva at the end of 2015. And in 2016, one of the first things we wanted to do was we need to create a sense of urgency. So there was a declaration that we had at the Bogota around this issue of unmet neurosurgical need, and we called it the Bogota Declaration. You can look that up. But it was really just a call to action, saying there's a huge unmet need of neurosurgical cases, and neurosurgeons, us, we should take responsibility and ownership of that problem, and we should work together to address that. And Walter Johnson was there. Franco Servidai was the president-elect for the WFNS. The Health Ministry of Colombia was there. And so this was kind of a call to action, creating a sense of urgency. The other thing we did was we needed to do some baseline research. What's the evidence? How big is the problem? So this is one of the first research projects that we published in 2018, looking at how many operations are not being done that needs to be done. 5 million, right? I mentioned this earlier. And most of it is in those countries that are in red and orange, Sub-Saharan Africa and South and Southeast Asia. And in order to meet that gap of 5 million operations, at that time we had 49,000 neurosurgeons in the world. We needed additional 23,000 neurosurgeons to meet that demand. And then we need to build a coalition, right? You need a little team to build on this message. And then that happened as a result of Franco Servidai. By this time, he was the president of the World Federation of Neurosurgical Societies. He was a neurotrauma specialist, as opposed to some of the previous presidents who were vascular, tumor, nothing against those guys, but neurotrauma. And he really saw that the unmet neurosurgical needs in these developing countries, more than half were head traumas. So there was a natural alignment with what he wanted to do, what he was doing and what we were doing. So he said, Kee, we're going to start a global neurosurgery committee, create your coalition, your committee, bring that together. And then we did. And our mission was simple, to align and coordinate all global efforts to collectively address the unmet neurosurgical needs of our patients. Pretty much what the Bogota Declaration called for. And then we created a coalition of the actors, and we created the definition of global neurosurgery. That was one of our first things we did. Then we needed to form a strategic vision. Where do we want to go with this? So we decided to come up with the global action plan for global neurosurgery. That's what we came up with. And this is what our action plan looked like. We had 5 strategic pillars. First was to amplify access. Second was to align global neurosurgery activity. Remember, WFNS is not a service organization. We didn't send teams out or anything like that. So it was more of the coordination effort, but amplify and then align. Advancing relevant research. And I'll tell you a little bit more about what these objectives had. Each one of them had targets. And I'll tell you, we'll go into a little more detail on the advanced research one. Assimilating neurosurgical capacity building with the overall global surgery movement. And then last is to advocate, right? Neurosurgeons, people listen to neurosurgeons, and we should use that voice for good. And so we should advocate for universal health coverage, inclusion of neurosurgical benefits package. And this was one of the first things that we did in the WFNS's first Global Neurosurgery Committee. And then we needed a team to execute. So we created a secretariat of basically medical students and trainees. There was, at that time, so many trainees and students who were saying, hey, this global neurosurgery thing sounds really exciting. How can we help you? Then we said, come on in, and we need your help. And so we created teams for each one of our strategic pillars to execute. And those are Army. And now many of them switched over to there's a new organization called Mission Brain. It's headed up by Alfredo Quinones and then Michael Lawton. And they have a medical school chapter. They have over 100 chapters around the world. If you haven't heard about it, maybe there's a chapter in the UK. Mission Brain is really has given students and trainees a way to organize regional country chapters and then bring their talent and resources together to help execute on global neurosurgery type of work. They have hackathons, they do podcasts, they do research. They've been amazing. So, and then now we're actually, and by 2024, we have an army of global neurosurgery, not just a coalition, but we really do have an army. That was the first ever global neurosurgery multi-day conference hosted by Tariq Khan, who's now the current Global Neurosurgery Committee chair in Peshawar. And that was in 2020. That was just the last year in February. And that was the first time we actually had a multi-day global neurosurgery conference dedicated to only global neurosurgery. Now, the next part is enabling action by removing barriers. And this is like when you take out like people that are in your organization that's standing in the way and getting them out. We did not have to do that, thankfully, because you really can't oppose global neurosurgery. So Nino Chioka, who's now the head of the combined global, the Mass General and Brigham neurosurgery department, the MGB neurosurgery now. By the way, they're starting a global neurosurgery center within the new department. And Nino Chioka says, trying to be against global neurosurgery is like not liking puppies. You can, it's not, because it's what we're trying to do is good. No one's trying to profit off of this thing. It's really an effort to help those who aren't getting neurosurgical care. So we didn't have to do any kind of active removal of barriers. So generating short-term wins. So as I mentioned, one of our strategic pillars was to advance relevant research, especially from authors in the developing world. And we had a number of targets. One was mapping research output by region and themes. Remember, global neurosurgery research is different than neurosurgery traditional research. There's a public health aspect of it, epidemiology, service delivery, financing. So we did that, it's published. Establishing global neurosurgery research grant and award system mechanism, we did that. The Neurosurgical Outreach Foundation from the US and Florida, they gave money and we created an award, a research award with that money. Advocating for global neurosurgery category and sections in major neurosurgical journals. You've seen this, right? The Red Journal's got a global neurosurgery section. The World Neurosurgery has it. The White Journal has it. European, the EANS journal, Brain and Spine, they had a dedicated issue on they call it humanitarian surgery, but neurosurgery. But we've succeeded in that. Not only have we succeeded in it, there's actually a new journal called Journal of Global Neurosurgery. So we exceeded our goals. Establishing funding mechanisms for training in future leaders in public health practice. The CNS fellowship is that example. Inclusion of global neurosurgery sessions in major neurosurgery meetings. We're having a dedicated multi-day global neurosurgery meetings now, and there's more planned on the way. So as you can see, these are the quick wins that we set for ourselves, and we hit almost every one of these targets, and some of them we exceeded. And these are the wins that we can publicize. So as I mentioned, Red Journal, White Journal, there are books on global neurosurgery. There's a new neurosurgical focus issue coming out in March on global neurosurgery. So there's all kinds of activities which far exceeded what we thought we had, what our targets were. So the meetings, right? There was a meeting in 2017 where Rick Boop, when he was the president of AANS, made global neurosurgery this theme of the opening reception. The first plenary session for global neurosurgery was in Istanbul. There's Ugo Ture. We convinced him to actually give us a plenary session. There's only like 10 people in the session. But we can say we got a plenary session at a major world congress. Anyway, so you can see what's happening in terms of the national meetings, international meetings on global neurosurgery. What we have now is country teams. So Tariq is now the head of the Global Neurosurgery Committee for the WFNS, and we have a team dedicated to building a neurosurgical capacity in Sierra Leone. And I'm just going to talk a little bit about that. Wow, we're almost at no? Okay. Okay. This is a combined health ministry and Mission Brain, WFNS. The Ministry of Health is buying the CT scanner. They allow 2 of their surgeons to be released from service to go to Rabat to be trained in neurosurgery. Mission Brain raised money to help pay for their training. One of them has come back already, is now saving lives back in Connaught. And so this is the way we should be approaching capacity building, a multidisciplinary comprehensive approach. And then to sustain acceleration, there's a number of things that are happening. I got to tell this group about this new WHO Global Action Plan on epilepsy and neurological conditions. This is the first time that WHO has adopted a global action plan on neurological conditions. And I will tell you, and it involves doubling the amount of research on this issue by 2030. Okay, that's one of the objectives. The other one is increasing coverage, reducing stigma, and developing policies. What's important about this is that when this, the IGAP is called, Intersectoral Global Action Plan, the neurologist had drafted this plan, and it did not include neurosurgical conditions, except like stroke. So we were able to insert traumatic brain and spinal cord injuries and cancers of the nervous system that broadened the definition of neurological conditions. So now it's included. So we are now part of the IGAP thing. So over the next 10 years, you will see ministries of health emphasizing the need to improve services for neurological conditions. This is an amazing opportunity for people like us, involved in global health and who are neurosurgeons and neurologists alike. We've done a number of work on informing policy. This has to do with advising ministries of health how they can manage not a clinical guidelines. These are recommendations for health ministries and how to improve. What evidence is there to strengthen health systems to manage at a country level head and spine injuries. Things like we use a methodology of health systems, the building blocks, and the continuum of care and management for head injuries, surveillance, prevention, pre-hospital care, surgical system, and so on. And we come up with a big rubric, but each one of those boxes we have recommendations that are evidence-based. So things like the number of neurotrauma centers should be placed in no more than 4 hours, right? This is different than the golden hour that most people believe, by the way. It's based on the new evidence. 4 hours is sufficient for now. One neurosurgeon per 200,000 people at a minimum, right, to meet the neurotrauma demands. We did one for spina bifida and hydrocephalus. This is what the recommendations look like. It's called CHISPR. And then, of course, this is another example of how neurosurgeons are now leading global public health efforts. And this one has to do with a resolution that was passed at the World Health Assembly last year, calling for folic acid fortification. We know that there's class 1 evidence of folic acid fortification reduces spina bifida neural tube defects. And I was amazed that neurosurgeons can lead a grassroots effort and succeed in getting countries to pass a resolution calling for folic acid fortification. Neurosurgeons are all over the advocacy space. Gail Rousseau, Jesus, Tariq, Richard, Rick Boop, we're all part of the G4 Alliance. And G4 is really a global surgery advocacy organization, but there's a big neurosurgical component to it. So just a little bit about research, and I'm almost done. In 2016, myself, Walter Johnson, and Bob Dempsey, after we met in Rome, we said, let's write an article about global neurosurgery. So we published this thing called Global Neurosurgery, the Unmet Need, and that was in 2016, and the research has taken off. I haven't done the latest in 2025, but global neurosurgery research has just exploded in terms of quantity and quality. And it's not just fringe. I'm going to give you an example. Global neurosurgery research is going to have massive impact. So one of the systematic reviews that we did to understand the unmet neurosurgical need, the 5 million, was we divided neurosurgical conditions into 10 buckets. And we said one bucket will be TBI. What is the global incidence of TBI? So this was a modeling paper that we did. Duan was our first fellow for global neurosurgery. He's a pediatric neurosurgeon in Vanderbilt. And that paper that was published in, I guess it's 2018, there's a thing called altmetrics. How many people know what altmetrics is? Okay, so some people know. I had no idea what that is. But when you look there, it sort of tells you what your impact is. So for that year, in 2018, I think outputs of similar age from that journal were number one, right, in terms of influence. But they also looked at outputs from the Journal of Neurosurgery. All of the articles, I think at least ones that they're tracking, we're at 7. And actually, I just checked the other day, we're number 5 now. So we've already climbed 2 notches. I think we're going to be number 1. Okay? I wouldn't be surprised. And here's the other thing. This was actually behind a paywall, right? $40 for downloading. It's been downloaded, full text views, almost 65,000 times. I don't know how much Journal Publishing Group is making on this, but they should give me a kickback. But the point here is that researching global neurosurgery is not fringe or not mainstream. It's huge, and it could potentially change. There's impact associated with it, not just in social, but from an academic standpoint. So and now we're in a position where we're institutionalizing change. We can see all these organized neurosurgery, forming committees. Your own society, the SBNS, they've created a global neurosurgery initiative. I think that's why I think one of your residents went to Jamaica, was based on the funding from them. So just about every organization is creating committees. There's observerships. And here's where I think where we are now. Neurosurgeons have always enjoyed a reputation as being master surgeons, and we should maintain that reputation, okay? Don't give up on that. I love that. People, oh, you're a neurosurgeon? Yeah. And we want to be that master technician. Let's keep it. You saw today the kind of research, right? The immunotherapeutics, CAR T cell, the AI for targeting, lesions. This is incredible science. Neurosurgeons should be at that forefront of being really clinician and basic scientists. We have that reputation. Keep going. But I think we've left out the global public health aspect until very recently. And now our identity should be all 3. Now, someone could be good at global public health. They might not be a good surgeon, technically, and that's fine. Or someone who's good at research may not be a good public health person. But we should all be part of that same group as a profession. And that makes us a better profession. That makes us who we are better. I'll finish with the upcoming Boston Declaration. It's in April, the day before the AANS meeting in Boston, April 24th. Please come. We have an entire day that we're planning on global neurosurgery, culminating with a 2-hour event at the Edward M. Kennedy Institute, which actually has the exact replica of the U.S. Senate inside. Edward Kennedy died of brain tumor. So we're going to have a event where we're going to get pledges and commitments and put us in a good place for next decade for global neurosurgery. We are institutionalizing global neurosurgery. So I'll finish with this. I know the global health is under attack. And I miss Paul. Sorry. Even now, I get a little emotional because what he stood for is what changed my life, and our country is turning back on this, and I won't do that. And I just hope that you will support us. And Paul Farmer believed that idea that some lives matter less is the root of all that is wrong with the world. We're seeing that today, and let's not make that happen. Thank you very much. I don't know, Ron. I don't know if I left enough time for Q&A.
Thank you. I think that was a tremendous lecture, a tremendous call to action, I would call it. I learned a lot. I enjoyed that. Although it's not traditional in these talks to take questions, Kee has agreed to take a couple if there are any questions.
Yes. Question? Yes,
ma'am.
Thank you so much for your talk. My name is Nahi Khan. I'm a consultant neurologist. I'm a British neurologist based in London in the southeast. I have to say I have the pleasure of sitting next to your wife. And I think behind every great man there is a great lady.
Yes.
So I think all due respect to your wife as well, considering what you've been doing around the globe. It's very impressive what you've been doing with the Global Neurosurgery Program. Can I ask you a question and then I'll tell you why once you've answered it? In the global neurosurgery program, perhaps unlike European or British neurosurgery, it's very clear to me what's essential part of that group are neurologists working alongside. So in the global neurosurgery program, because you are going out to countries where primary care is probably non-existent, neurologists probably don't exist, and those that are out there are really struggling. Do you have neurologists as part of this great plan?
No, it's a great question, and the answer is not yet, but we're planning to change that. So at the Boston Declaration, one of our attempts is, one of our issues that we recognize for the first decade of global neurosurgery is that it's been surgeon-centric, and our tent has been too narrow. We really need to expand that tent to include not only neurologists, but anesthesiologists, nurses, technicians, allied health, but even beyond health workers, innovators, finance, development officials, policymakers. But so we are going to try to enlarge that tent. And then the IGAP, the intersectoral global action plan, is designed exactly for that reason, to make neurologists, mental health experts, neurosurgeons all come together under brain health, let's say, right? So we.
I think the main reason for me asking that question, so I'm basically a volunteer for an international British NGO that has been sending neurosurgical missions to the Gaza Strip for many years. And what is very clear from that work is that it's not only a global neurosurgical program, it's also a program of when it's not neurosurgical, when you're not meant to operate. And what's very clear is that you need neurologists out on your neurosurgical missions with the teams going out. So I think just in terms of what's going on the front line, it's neurologists that are supporting the neurosurgeons in these areas. So it's just a recommendation. I'm sure there are many British neurologists around the world who would join your program, because it does give neurologists the opportunity to work alongside our colleagues, because we as neurologists don't always have that opportunity. So,
Yeah, the neurologists are actually pretty well in the global health space. There's a World Neurology Federation, I think. I think that's there's a World Stroke Organization. There's a number of organizations that are working together to help implement the intersectoral global action plan on epilepsy and neurological conditions. And it's not my program. Our program is more training of future leaders in global neurosurgery and global surgery. But I'm happy to talk to you further about any contacts that you may have that we can make that bridge. Global neurosurgery, global health is not an individual sport. It's not for people who can say, hey, it was me that took that tumor out. It's totally different. The paradigm requires all of us to work together to achieve a system level change. So I welcome, collaborating.
Addy?
Thank you for an inspiring talk. Is there a problem about brain drain from resource poor settings to higher income countries? And if so, how does one propose to deal with that particular problem?
Yeah, this came up at the executive board meeting of WHO just last week. And there's an attempt to put some guidelines to it. For sure, this is a problem, right? Ethiopian doctors trained by, they went to the Ethiopian education system and subsidized by the government and the training, and then they leave the country and they come to US, or I'm not just picking Ethiopia as an example, but there are other countries too. It's bad, right? Because high-income countries, we benefit and we never pay for their education, right? And then it's a huge hit for the country that's losing that doctor. There's actually a movement by countries on the brain drain side saying, UK should pay us and reimburse us for the cost of educating these doctors. I like that because it really, not that I support retribution like that, but it really puts the high spotlight on the problem, right? People need to take responsibility, and they say, well, people should be free to sort of go where they want to go. Well, it's not. There should be some regulations behind it. It's a big problem.
I just want to follow up on comments. So regarding the collaboration of neurology and neurosurgery, after the WHO declared neurological diseases one of their top needs in the world. There's more collaboration. Two of the biggest organizations, International League of Epilepsy, together with the IED, actually they have launched one of the largest surveys, replying what are the global needs for epilepsy, and the production of the data is going to happen in the months to come. That's one, so that's good outcomes from a multidisciplinary team. Two, I have two questions for you. So global neurosurgery has been a boom since the Lancet Commission. We've seen a good positive trend. In the chronic and local implementation of neurosurgery around the world. So, but how about times of crisis, right? We saw the needs of surgical care, but most significantly, the lack of neurosurgical care provided in areas of crisis. We've seen Gaza, we've seen Nepal, we've seen Haiti, right? The major forces that are moved are obstetrics, orthopedics, general surgery. So that's one. And two, do you think that maybe global neurosurgery should be part of our training curriculum? Those are the two things.
Yeah, I'll go backwards.
Sorry.
The last part is yes. I think actually all physicians should be given public health. Public health should be part of medical curriculum. And there's a big reason behind that. We tend to think that being a medical doctor, we can fix all health issues. But if you take a big picture and saying what actually influences the health of a population, medical care is just the one little sliver. And usually it's expensive and it's too late, right? It's so much better to prevent and take up there's socioeconomic issues, there's lifestyle issues, there's political issues, right? And there's battle, conflict. So yes, I believe that some public health training should be part of residency, but also should be part of medical school curriculum. I'm not sure if that's the case here. In the U.S., is really not being taught. It's an option, but it's not mandatory. I don't have a good answer about conflict zones. We typically work with ministries of health, and it's more of the public health system that they focus on. I will tell you that there was a new resolution at the World Health Assembly 2 years ago calling for emergency critical care and operative care, strengthening as an integrated service. And we've been having consultations around what that means. It may be that strengthening those services will be help build more resilience in terms of conflict and natural disasters. But once again, I don't have a lot of experience in working with conflict zone people. But I would love to talk to them. It's an area that is of interest to me.
Okay, on that note, join me again in thanking Kee for just an absolutely wonderful lecture, and then we can go out and there should be a reception there. Kee, thank you very much. Oh, and